Well, good afternoon, all. We'll continue on in our spinal cord injury lecture series. Today I'll be talking about bowel management after spinal cord injury. We'll talk through the neuroanatomy, including both the intrinsic nervous system as well as the extrinsic nervous system, the bowel anatomy and physiology, colonic reflexes, and then defecation and ways that we can optimize that for persons with spinal cord injury. Those of you who remember going through potty training yourself, go ahead and raise your hands for just a second. Oh, wow, there's more than I expected. So I can't remember. I don't know if it was multiple concussions after that, but most people, believe it or not, don't remember, except for obviously PM&R residents, and you guys are a special group. But it's really difficult when you consider what you had learned and forgotten that it was even a problem, and then suddenly you have no control of your bowels. And so we're going to talk through the GI tract a little bit, what we should and what we shouldn't have control over, and why it becomes so necessary for us to manage appropriately with spinal cord injury. So obviously the purpose of the GI tract is to provide fluid and nutrients to the rest of the body. We usually take in somewhere around 800 grams of food and somewhere between 1 and 2 liters of water. In the midst of passage through the GI tract, we secrete about 7 liters of fluid, and that includes from the salivary glands, stomach, gallbladder, pancreas, and intestines, and yet we reabsorb 8.5 liters. So at the end of the day-ish, we excrete approximately 150 grams a day of fecal waste. Now, again, we don't think about this, and we don't consider all aspects of the innervation that we don't particularly have control over, but it's very important for us to review these as we talk about managing neurogenic bowel after spinal cord injury. So what we're going to follow here is everything that you see in these red lines. The red lines are going to represent sympathetic nervous system, and particularly sympathetic efferents. The blue lines are representative of parasympathetic efferent fibers, and the green, there aren't many, but the green basically are the somatic efferents. The afferents are the solid black lines that come all the way back to the cord and typically would ascend up to the cortex and let us know things that are going on there. So as a starting point, very much like the heart and the cardiovascular system, the GI system has a number of pacemaker cells, and the pacemaker cells are a little different in the stomach as opposed to the small bowel and the large bowel. And so recognize that because the GI tract has its own intrinsic innervation, it can move forward, propel food, etc., digest food, and ultimately prepare it for elimination from the body in and of itself. Now, we have external influences that we'll talk about in a moment that can modify the intrinsic nervous system activity. However, the enteric nervous system, the intrinsic nervous system, basically is comprised of the Meissner's plexus and Auerbach's plexus. You all remember these as bundles of nerve that cause contraction of the smooth muscles within the GI tract. Ultimately, this allows us to propel food forward, as well as mixing and grinding it up as it passes through the different aspects of the GI tract. So the pacemaker cells in the stomach fire at about 3 to 5 times per minute. And obviously, this activity increases somewhat as we've just had a meal. We see about, 2 to 5 times as frequently small bowel contractions, that is contractions in the duodenum, and then irregular colonic contractions. So you have this entire symphony going on in the GI tract. It would seem that it would be completely related, and it mostly is until you get to the large bowel, and then things become a little bit more irregular. So again, as we talk through these, I want to talk through the different aspects of the extrinsic innervation. We talked about the intrinsic innervation to the bowel that is under influence of the somatic nervous system, the sympathetic nervous system, and the parasympathetic nervous system. So the somatic nervous system allows us control of the external anal sphincter and the pelvic floor musculature. So get in touch with your pudendal nerves for just a moment and just recognize the control that you have through activation of your external anal sphincter and pelvic floor musculature. You probably aren't as aware of sympathetic activation. Remember, this comes from 22 pairs, right and left side of the paravertebral ganglion. And particularly of note in the GI tract, you have the superior inferior mesenteric ganglia from T9 to T12, and the hypogastric nerve from T12 to L3. The sympathetic nervous system, remember, this is activation of fight or flight. And so during a fight or flight crisis, the sympathetic nervous system is going to slow down GI motility and secretions, and it's going to maintain internal anal sphincter tone, hopefully. Now, the parasympathetic nervous system, remember, arises from the cranial sacral nervous system. Cranial portions basically are mediated through the vagus nerve, and that includes from the mouth all the way to the mid-transverse colon. The sacral parasympathetic fibers, S2, 3, and 4, basically supply innervation to the mid-transverse colon all the way down to the rectum, and then the pelvic nerve increases motility of the colon and provides relaxation of the internal anal sphincter. So the purpose of the parasympathetic nervous system, after the crisis situation is over, the parasympathetic nervous system is rest and digest. So it's responsible for increasing peristalsis and gut motility, stimulating secretions, and relaxation of the sphincters as we go through there. So defecation is usually a fairly well coordinated event, and it takes into account the position of the body. It takes into account recent ingestion of food and or fluids, and basically is going to be activating through the pelvic splanchnic nerves reflexes to allow for emptying of the rectal vault. So we know that we have influences, particularly the pudendal and levator ani nerves, that allow us control over the pelvic floor musculature and the anal sphincter. The pelvic splanchnic nerves basically are going to be coming in and promoting relaxation of the internal sphincter. So typically you maintain control of your sphincters through the internal anal sphincter and the pelvic floor muscles, as well as the external anal sphincter. The internal anal sphincter tone is inhibited when you have fecal material in the rectal vault. And so that actually causes relaxation of the internal anal sphincter. And then you have voluntary control of your abdominal muscles, relaxation of the puborectalis and the external anal sphincter, allowing for defecation. So just as a reminder, with regards to these different muscles, the puborectalis muscle, when it is contracted, actually prevents defecation. So it requires relaxation of the puborectalis and the external anal sphincters in order to have appropriate defecation. If these are spasming, then it's very likely that you will end up with constipation, significant hemorrhoids, as you're trying to defecate in normal fashion. So we keep this in mind. You can develop this rectosphincter dysinergia, very similar to the detrusor sphincter dysinergia that we see in neurogenic bladder. And this is a major problem that we have to overcome in our folks with a true spinal cord injury or upper motor neuron bowel. So I want to talk through the colonic reflexes. There's the colocolonic. So as you have a stool distending In the colon itself, the myenteric plexus is also going to respond with contraction and propulsion of the stool forward. The gastrocolic reflex, as you distend the stomach, approximately 30 to 60 minutes later, you will see contraction and increased propulsion of stool through the gut and into the rectum. You have the rectocolic, so as the rectum is distended, that will also stimulate colonic peristalsis. And recognize that the rectocolic reflex can respond to both mechanical as well as chemical stimulation via the pelvic nerve. And so we use those as in the form of suppositories and digital stimulation to optimize the reflex responses that are left for a person with an upper motor neuron bowel. The anorectal reflex results in relaxation of the internal anal sphincter, particularly when you have stool in the rectal vault, and this will promote, hopefully, defecation. And the bulbar cavernosus reflex, while it doesn't contribute to defecation, it's important for us to be able to recognize the integrity of the somatic nervous system. So the bulbar cavernosus reflex, remember, is as you're doing your rectal exam, you reach around, tug on the glans penis or the pubic hair, and you will have an afferent response to the cord that ultimately causes contraction of the sphincter around your finger. And so that indicates that you have an intact, that is an upper motor neuron system. The lower motor neuron elements are completely intact, both afferent as well as efferent. And so this will tell you that you're going to be able to use particularly the suppositories for their chemical and digital stimulation for mechanical reflex activation of the gut. So how do you maintain continence after a spinal cord injury? We know that digestion and absorption will continue to be intact because of the intrinsic nervous system. The colonic transport, however, is somewhat slowed. And the primary muscles that maintain continence in folks that are not, who do not have a spinal cord injury include the internal anal sphincter, which has components of the hypogastric nerve, the sympathetic fibers, as well as the pelvic nerve, S2, 3, and 4. And then you have typically somatic control, voluntary control over the external anal sphincter, the puborectalis, and the levator ani. So one of our major issues, again, when we have a high either paraplegia or a cervical tetraplegia, is autonomic dysreflexia, first described by Anthony Bowlby back in 1890. This basically is reflecting a noxious stimuli below the level of the injury that causes a reflex sympathetic outflow and ultimately causes a hypertensive crisis in persons with injuries above T6 and potential complications including stroke, seizures, organ failure, and death, all of which would be suboptimal. So we know that the number 2 cause of autonomic dysreflexia is in fact bowel related. So a distended bowel, an ileus, or constipation can cause autonomic dysreflexia. Diarrhea can cause autonomic dysreflexia. Acute abdomen, and sometimes an ugly one, can cause autonomic dysreflexia. So appendicitis, cholelithiasis, cholecystitis, and ischemic bowel. All of these you would typically the person would have extreme pain, but not if they have a spinal cord injury. They may just have this reflex sympathetic outflow resulting in autonomic dysreflexia. Similarly, a hernia, abdominal trauma, and cancer all can contribute to autonomic dysreflexia. And as a reminder, this noxious stimuli below the level of the injury sends afferent impulses up the cord, but they are blocked at the level of the spinal cord injury, and you get this reflex sympathetic outflow that causes splanchnic vasoconstriction and hypertension. Increased blood pressure is sensed by baroreceptors that send information to the medulla, which sends information back to the heart, resulting in a relative bradycardia. But below the level of the injury, the person remains vasoconstricted. Above the level of the injury, you see flushing, sweating, and this pounding headache that we associate with autonomic dysreflexia. So our goals in bowel management are to provide predictable and thorough evacuation so that the person doesn't have to worry about having a bowel accident while out in the community or while socializing. Ideally, this would include the absence or at least control of constipation, diarrhea, and prevent autonomic dysreflexia. Maintaining bowel continence is a major goal that contributes to improved quality of life and patient satisfaction, physically, economically, and socially. However, a goal without a plan is just a wish, as you all know, and so we have to be a little bit more specific in terms of how we're going to provide these goals in way of intervention to meet the goals themselves. Now, persons with spinal cord injury, you've heard this before, but I'll just say it again, are very, very concerned. One of their highest priorities is bowel and bladder management. For those with tetraplegia, only arm and hand function, sexual function, and truncal stability are listed as higher priorities for these folks. Those with paraplegia, only sexual function is listed as a higher priority than regaining control of bowel and bladder. So Kim Anderson put this together back in 2004. Kim was actually an associate professor here at the Miami Project, recently has moved up to Cleveland, Ohio, and is working with the group there in their model systems program. So we recently had a call to pursue more bowel management research, and a couple of groups had put together papers. One of those, Greg Holmes, basically, and colleagues talked about the preclinical outcome metrics that needed to be looked at with spinal cord injury. This is particularly with regard to animal research, looking at immunochemistry of the intrinsic nervous system, fecal analysis, whole gut transit studies, motility studies of the distal colon, and colonic smooth muscle tension recordings, with the idea that these could then be extended to human research. And the human research includes clinical outcome metrics. Denise Tate out of Michigan and her colleagues had put together the paper on clinical research that would include bowel diaries, imaging studies, endoscopy, colonoscopy, gastric emptying studies, including wireless motility capsules, anal rectal manometry, so actually looking at gut pressures, and then pudendal nerve conduction velocity and pelvic floor EMG studies. These were to be tied together with subjective reports of quality of life, especially the Qualavine 30 short form, the SF Qualavine, and the Neurogenic Bowel Dysfunction Score. I know that that seems like a lot of mumbo jumbo to you. However, again, these are priority areas of research for persons with spinal cord injury, and the animal researchers and clinical researchers have been given a special plea to move forward with research in these areas. So that said, let's talk about managing the acute upper motor neuron bowel. So as we bring folks over from the acute service into inpatient rehabilitation facility, we want to have them upright on the padded commode if at all possible, otherwise left side lying in the bed. Now, this is one of those areas I continue to see an opportunity for improvement in our rehab center. I am still coming in, meeting with patients in the morning, asking how their bowel care went. Not so good. Were you upright on a commode? Oh no, I was in bed. And so this is one of those areas that we need to write explicit orders to have the bowel care program while the person is sitting upright on the commode, to allow gravity and to allow the full opening of the anal sphincters as we're going through there. Initially, I would recommend daily bisacodyl and polyethylene glycol. This is the magic bullet suppository. It is different than the usual bisacodyl suppository, which is a vegetable oil base. So the usual bisacodyl suppository takes about 3 hours to melt, and therefore The persons, generally speaking, aren't going to have as robust a response, and certainly not spend as much, or they're going to be spending much more time trying to do their bowel care, as opposed to the polyethylene glycol base, which melts within 15 to 30 minutes. And therefore you have full chemical exposure to the rectal vault, and a much more robust rectal response to that. So ideally you would be providing this 30 minutes after a meal, and then providing digital stimulation 30 seconds every 10 minutes for up to an hour. And then you're going to ask the nurses to document results. Again, a show of hands, how many are actually asking for the nurses to document the results? That's something that I would like us to include in our order sets, okay? And we're going to talk about how we would like to ideally see that reported. So for persons with spinal cord injury above T6, we want to document their baseline heart rate and blood pressure after each digital stimulation, and then following your autonomic dysreflexia quick orders, as we've talked about a couple of weeks ago. Now, while the person is on the commode, encouraging abdominal massage, weight shifts after each digital stimulation, again, trying to optimize defecation. And once the bowel care results in no stool, but you just get mucus on a daily basis. So you did it yesterday, you got a good result. Today you do it again and you only get mucus. Then we can consider switching to an every other day bowel care program. So once you're only getting mucus, that's the clue that you've been emptying your bowels sufficiently to be able to go to an every other day regimen. Now, things that you could use instead of the magic bullet suppository. Enemies is that mini enema, and you can provide that PR as well. Enemies Plus is the same thing, but with an anesthetic, so that the person would not, so if they're having autonomic dysreflexia responses to magic bullet suppository or the Enemies suppository, Enemies Plus might be a good way to go, so that we can still get good evacuation, but without autonomic dysreflexia. Next in line would be the glycerin suppository. And then last on my list is the bisacodyl and vegetable oil, because it just takes forever and a day, and we don't have that much time. So we should have quick set orders for you to be able to put in this type of a bowel care program. If you're not able to find those, I guess reach out to me and let me know, and or Tricia DeVoe, so that we can make sure that we're getting these orders on the charts appropriately. So lower motor neuron bowel management is going to be similar, except we can't use the chemical and digital reflex maneuvers. So now we're going to end up having to use digital disinfection, ideally 30 minutes after a meal. Remember that the stomach to intrinsic nervous system is still going to be working. And so when you distend the stomach, approximately 30 to 60 minutes later, the bowel intrinsically is going to move, and that would be an optimal time to move forward with your digital disinfection. Again, upright on a padded commode if possible, otherwise left side lying, and then encouraging abdominal massage, weight shifts, and trying to get the documentation for the stool amount and consistency. What does that even look like? How fun is this? Just take a deep breath and recognize this is what we are asking the nurses to document for us. This is the Bristol stool scale. So the BSS, take that however you'd like. Type 1 is just basically rabbit droppings. So you have separate little hard lumps. This is suboptimal, and it basically tells you that you've got a significant problem with constipation going on. A bunch of grapes is sausage shaped but lumpy. Corn on a cob is like sausage but with cracks in its surface. The sausage is like a sausage, smooth and soft. Or you get little chicken nuggets, soft blobs with clear-cut edges. That's type 5. Type 6 is it comes out looking like a porridge with fluffy pieces, ragged edges, and a mushy stool. And type 7 is gravy. That is watery with no solid pieces, entirely liquid. I would ask that you, when you put your orders in for documentation, that you ask them to document according to the Bristol stool scale. not school. The Bristol Stool Scale. Say that 3 times fast. Otherwise, the BSS. The equipment, ideally, that folks are going to be using will have been provided by occupational therapists, and the nurses working together with the OTs are training the patients and our families on how to use these appropriately. It may require a specialized chair that allows for recline, that allows for those folks who don't have good truncal balance to be able to be safe. And so these chairs are can be up to $6,000, just so that you know. Not everybody needs one, nor should everyone be provided one, but those with high cervical injuries, you would want to be considering this. And this can also be used as a shower chair. Using the suppository inserter and the digital stimulator for those folks who can't reach around enough to be able to do full digital stimulation. These tools are going to be necessary in order to get a good response. And then again, ideally in a pouted commode system, if they don't have truncal support, go to these more expensive but also safer bowel and bladder management chairs. So talking through the neurogenic bowel then, upper motor neuron versus lower motor neuron. We're going to talk about the bowel care strategies using reflex evacuation as much as possible for the upper motor neuron bowel, recognizing that the lower motor neuron bowel is going to require passive evacuation as we go through there. So again, upper motor neuron injury, your final common pathway, the lower motor neuron, should be intact. And so the major issues are hyperreflexia of the bowel, hyperreflexia of the pelvic floor musculature, and the levator ani as well. Recognize that defecation is not going to be voluntary with an upper motor neuron bowel, and we're going to take advantage of the reflex arcs between the cord and the colon that remain intact in order to optimize complete evacuation of the bowel. So having the person sitting upright on a commode if possible, and using a diet high in fiber. We're going to talk about that. That also needs to be accompanied by a sufficient amount of water. If it's not, they're likely to become constipated. And so this is our balancing act between bowel and bladder, trying to maintain them so that they're not making too much urine, so that they don't have to cath themselves more than 6 times a day. And in this case, we're looking for consistency of a soft formed stool. So somewhere around a Bristol stool score of a 4 would be ideal. Using bulk forming agents, stool softeners, we're going to talk through those a little bit, as well as the stimulants. Remember those contact irritants, the chemical bisacodyl suppository, ideally the bisacodyl with polyethylene glycol, followed by digital stimulation, we'll talk about in just a moment. The timing, again, 30 to 60 minutes after a meal. Some folks prefer to do this in the morning, particularly those who are working throughout the day. Other folks prefer to do it in a little bit more leisurely fashion, and so long as they're getting a good result without having bowel accidents in between, a nighttime regimen could be okay for them. So ideally, we want to do this every day until they're regular, and then we're seeing mucus on the days in between, switch to every other day bowel care program. Ideally, we keep the bowel time less than an hour and are able to maintain fecal continence, and we're not having problems with bowel accidents during the day. So the digital stimulation, this includes a circular motion with the wrist, gentle pressure to the bowel wall in a 360-degree arc for approximately 20 to 30 seconds, repeated every 10 to 15 minutes, but it shouldn't last more than 1 hour. In between the digital stimulations, I encourage the person to do weight shifts and abdominal massage. One thing of note is that the bladder program should precede the bowel program. I'm going to pause for just a second and ask anyone to tell me why it would be better to do your cathing before you do your bowel care program.
So you don't have an accident when you're doing your bowel program?
Potentially. Recognize that what is the #1 cause of autonomic dysreflexia?
Bladder?
Yeah, so the bladder. So if the bladder is distended before you start to do your bowel care program, and then you try to do your bowel care program, not only will you get more autonomic dysreflexia, but you have this sympathetic nervous system that is going to slow down bowel transit. And so you want to empty the bladder first so that you minimize the sympathetic outflow to the bowel as best you can before you start. So good points being brought up there. Again, recognize that most folks should recognize the need to do their bladder program before the bowel program. Oftentimes, those who don't are going to have more problems with autonomic dysreflexia and have a less effective bowel care program. So always do your bladder cathing before you do your bowel care program. Now, what about a lower motor neuron bowel? This is essentially an areflexic bowel. Your final common pathway is broken either at the afferent or the efferent or both loops as you're looking through the final common pathway. So remember now you've got injury at the sacral elements. And so this is like a cauda equina injury. Your myenteric plexus and Auerbach's plexus, the intrinsic nervous system of the gut is still intact. However, you don't have the spinal cord mediated reflexes. Therefore, you're not going to benefit from using suppositories or digital stimulation in this scenario. Also recognize that your external anal sphincter is going to be completely flaccid. So this is just like you see the legs with a flaccid paraplegia as opposed to a spastic paraplegia that you would see with an upper motor neuron injury, spinal cord injury. When you have flaccid lower extremities, you also have a flaccid sphincter. And recognize that this is going to make it more likely that the person will end up having a bowel accident if they've got anything in the rectal vault when they go to do a pressure relief, for example. Things will just scoot out. And so as much as possible, we want to be able to keep them emptied, especially during the times of the day when this would be socially inappropriate. Now notice also that you might appear to have somebody who maybe they've got a high paraplegia or even a cervical spinal cord injury, and yet they are unresponsive initially to the suppository and digital stimulation. That's because they are still in spinal shock. And so during that period that they're in spinal shock, they will not have those reflex arcs working. But you will know as soon as those reflex arcs do start working, you'll experience autonomic dysreflexia in response to your bowel care program. And usually we see this resolved before the person goes home from acute rehabilitation, usually. So how do you execute a lower motor neuron bowel program? Now you've got them, did I mention upright on the commode, using gravity as much as possible. Again, a high fiber diet as tolerated. The consistency now is going to be a little closer to the Bristol Stool Scale 3 and or a 2, depending upon the individual. So you want to have a firm but not hard consistency with your bowel movements. You're going to use bulk forming agents and stool softeners to that effect. You're not going to be able to get the benefit of either mechanical stimulation with digital stim or from your suppositories. So the chemical suppositories that we used in upper motor neuron bowel generally is not going to work with a lower motor neuron bowel. On the other hand, you usually aren't going to have to worry about autonomic dysreflexia if you have a lower motor neuron bowel. So again, you want to optimize timing for the gastrocolic reflex, so 30 to 60 minutes after a meal. Most folks prefer doing this in the morning. That way they don't have to worry about a bowel accident through the course of the day, but it also means that they have to get up early to get this done. And typically we'll have breakfast in order to try to help move this along and then be able to get to work, school, whatever it is that they're going to do during the course of the day. You almost always need to do this on a daily basis, and some folks may need to do it twice a day in order to maintain continence. As they are on the commode, encourage them to use a Valsalva. They're going to need to use manual disinfection, abdominal massage, and weight shifts as necessary. Again, the key thing here is you've got a flaccid sphincter. And so any shift in their weight, if they go to do a pressure relief, that could result in a bowel accident unless they've completely emptied the rectal vault with an effective bowel care program. So how do you determine effectiveness? Essentially, you're going to want to provide either that firm stool or a soft stool, depending upon if you have a lower motor neuron or an upper motor neuron bowel. Recognize that certain foods, spicy foods, greasy foods, can also stimulate a bowel movement. And so those types of things in a diet are going to potentially sabotage your efforts to keep the person continent. So make sure that they are aware in advance. Coffee is another thing that can help stimulate a bowel movement. And so if they use that to their advantage, that's great. So those doing a morning bowel care program have their coffee first, and that can help facilitate things. But recognize if they're going to continue to have coffee through the course of the day, if they're going to have spicy foods or greasy foods, that they're more likely to have a bowel accident because of that. And so they need to modify their diet appropriately. Increasing their level of activity is going to improve GI motility as well. And again, this is going to be a person's choice, whether they want to do the bowel care early in the day or late in the evening. Either case, it's more effective after a meal, 30 to 60 minutes. So the frequency with an upper motor neuron or a spinal cord injury bowel, ideally every 2 or 3 days. And yet for a lower motor neuron bowel, most of the time they're going to have to do this daily. Ideally, did I mention seating? So if you're sitting upright, gravity has a better chance of assisting you as opposed to left side lying or right side lying. You want to try to get the bowel care done in less than an hour overall. If you're only getting mucus, then you may be doing your bowel care too frequently and can consider extending time in between. And I guess the other thing is, as outpatients usually, when somebody comes to me and they're having problems, they've been doing well, but now they're having problems maintaining continence, we will try to effect just one change through every 3 to 5 bowel cycles. So we'll have to stay in touch with them as an outpatient and talk to them about, instead of using, just the digital stimulation, it appears that you're going to have to use a suppository and stimulation. Or if they're having problems with significant autonomic dysreflexia, do we use the suppository with a lidocaine jelly, for example, might be an opportunity. But you want to have them have 3 bowel movements at least before you go to effect another change. So your physical examination is going to be important for these folks, whether it's inpatient, outpatient. Acutely, we're going to want to do the rectal exam so we can determine if the person has an upper motor neuron as opposed to a lower motor neuron bowel. Recognize that pharmacological management is going to start with fiber, and there's a number of different types of fiber. Some are tolerated better than others. So the psyllium, the methylcellulose, these tend to be a little bit more gritty and not as well tolerated as some of the others. So calcium polycarbophyl or PEG, Fibercon, Benefiber, all of these may be effective. And so it's up to the person to find out which one they tolerate the best, but recognize if they're going to be increasing their fiber, they're also going to have to make sure they take appropriate water. And then you've got to balance out their bladder management. Stool softeners are essentially provided to emulsify fat. Remember, these are going to reduce the water reabsorption and increase the water content of the stool. So stool softeners include DOS, docosate sodium. or docosate calcium. They aren't going to improve the transit time or the peristalsis, but they will help to soften the stools. And then lubrication, this is to prevent injury to the rectal mucosa. Remember, injury to the rectal mucosa could cause autonomic dysreflexia and spasticity. And so you want to prevent that by using appropriate Surgilube or KY jelly. If necessary, you may have to use a lidocaine jelly in order to prevent autonomic dysreflexia. So also with regards to your bowel management options, I use these sparingly, the laxatives, whether they're salts, sugars, or PEG. All of them are likely to contribute to electrolyte abnormalities and ultimately a lazy bowel. That is a bowel that doesn't respond well to chemical or mechanical stimulation. So mag citrate, milk of magnesia, if you absolutely have to, I would use these sparingly. You can also use the synthetic disaccharides, lactulose, glucitol, the sugar alcohol, sorbitol. Again, recognize that these may contribute to a, quote, lazy bowel in the long run. These folks with a spinal cord injury now recognize they're going to be dealing with bowel management for the rest of their lives. And that may be 20, 30, 40, 50, in some cases 60 years. And then finally, Senna. I like to use Senna in the acute rehab setting. It stimulates the Auerbach plexus and actually helps with propulsion as you're starting out with your bowel care program. But I usually try to wean folks off 6 to 12 weeks after their spinal cord injury, because one of the known complications is melanosis coli. That is, you can develop essentially a lower motor neuron bowel. The intrinsic bowel can become atonic with the chronic use of Senna. So also consider pro-motility agents. This is to promote both gastric and colonic motility. Bethanechol is off-label. It's a muscarinic cholinergic agonist. You can consider anticholinergic anticholinesterase inhibitors like neostigmine. And this can be provided either IV or by iontophoresis. This is not commercially available, and I don't think it's considered the standard of care yet. I know that it's under investigations in at least 1 or 2 centers across the United States right now, but this can stimulate high amplitude colonic peristalsis. The side effects include drooling and bronchospasm and cardiac arrhythmias. Those don't sound good, but if given with glycopyrrolate, then this will promote bowel evacuation without having those cardiopulmonary side effects. So again, under investigation, not considered standard of care at this time, and yet may be something that we're going to be using in the future. Prokinetic agents, otherwise tegaserod or Zelnorm, is no longer, I don't believe, available except for IND protocols. Metaclopramide or Regland, remember, is a cholinergic agonist and an antagonist for dopamine. This is going to improve gastric but not colonic motility, and is often wrought with extrapyramidal side effects, so dystonias and sedation. It's certainly contraindicated with those who are taking MAO inhibitors or antidepressants. And then consider cisapride propulsid, which is going to activate the myenteric plexus. Again, this I don't believe is commercially available anymore for this use because it had increased QT intervals and caused episodic torsades de Pons. So there are others that we could be considering, the new opioid receptor antagonists. So for those that are on opiates, consider using these medications, naloxegol or methyl naltrexone, basically, and these are only for those folks who you feel are constipated because of their opioid medications, typically for pain. Erythromycin is still one of the fallbacks. It can stimulate motilin receptors in the upper GI tract, not as effective in the lower GI tract. So Contact irritants, so we've mentioned a little bit. This is purposely trying to elicit a contraction of the rectal vault. And so the bisicotal suppository, ideally in the polyethylene glycol base, will melt in about 1 hour, as opposed to the Dulcolax suppository, which is in a vegetable oil base and typically takes about 3 hours to work. Not very effective, and yet my understanding is this is still the only one that we have available on the inpatient service. I had put in a request to have the magic bullet available. Maybe you guys can reach back to me and let me know if that's actually on formulary now. Enemies is a mini enema containing DOS, polyethylene glycol, and glycerin. And then the Enemies Plus is similar, except that it also includes benzocaine 20 milligrams. So these are for folks who are having significant autonomic dysreflexia and or are sensate and are feeling the chemical burn of the bisicotal suppositories. I don't like to go there, but if I need to, I'll use Fleets and Soapsuds enemas to expand the lower colon, promote evacuation. And again, the smog, saline, mineral oil, and glycerin treatment is used by some folks who have kind of run through the other options and they found that those are not effective. So this is also available, typically 50 cc's each in 1 liter enema as you're going through there. Actually, a couple of very good manuscripts available at conceptsandconfidence.com that talks about these different agents and the relative efficacy as we go through there. There are other options. So for folks who are developing a lazy bowel, for example, those with intractable constipation or impaction, fecal incontinence, and significantly high bowel times, then we might want to consider transanal irrigation with a retrograde enema. This is using a rectal catheter, inflatable balloon, and a manual pump. And so these systems are effective for some folks. I found particularly for lower motor neuron bowels. Recognize that for some individuals, they prefer a surgical procedure just because this provides them the confidence they need to go out in public and to resume the quality of life that they hope to have. So that might require a colostomy, or the Malone anti-grade continence enema system is basically they use the appendix and use that as a continent catheterizable stoma, and they provide an antigrade enema, basically flushing from the appendix forwards as you go through this. And I've seen it used primarily in spina bifida, myelomeningocele, and lower motor neuron bowels, so children, but I know that it's being done, at least in some centers, fairly routinely for adults as well. The bowel stimulation systems, as are also used for bladder, you can simply push a button and it will stimulate contraction of the rectal vaults and relative relaxation of the anal sphincter. They set up the stimulation parameters a little different to stimulate the bowel than the bladder, although typically they're using the same nerves for both. But they found that if they change the stimulation patterns, they can routinely activate either bladder or bowel as necessary. So some ongoing complications associated with neurogenic bowel include bloating and abdominal distension in more than 50% of our folks. So typically when they're inpatient, using simethicone is going to be helpful, if not essential. Almost 60% of folks will develop hemorrhoids and or some rectal bleeding at some point in their time with a spinal cord injury. Recognize that most of the time you can manage this with small hemorrhoids and steroid cream, but in some cases they actually need to be surgically banded. And the point there is yes, they will typically come back, but if you can get rid of the noxious stimuli. So not all hemorrhoids are painful. And so if you can get rid of the noxious component, even though the hemorrhoids most likely will recur, you can prevent episodic autonomic dysreflexia. Fecal impaction occurs in about 15% of our folks. Right colonic impaction with those of upper motor neuron, and left colonic impaction with those with lower motor neuron valves. So constipation, common in spinal cord injury, and is usually worse because of a lack of dietary fiber or too much fiber without fluids. And for those folks who are simply not out and about much, so those at forced bed rest, for example, because of a wound, have a double whammy. Number one, they're not getting the activity-based stimulation to the gut, but the wound itself may also be causing sympathetic outflow to the gut, again, making it more likely that they will develop constipation and slowed motility. Certain drugs, obviously, the tricyclic antidepressants, anticholinergics, narcotics, and some antibiotics are going to change and contribute to either constipation or diarrhea. Folks with spinal cord injury are at risk for the same things that those without spinal cord injury are at risk for. So colon cancers, hemorrhoids, fistulas, hiatal hernias, abdominal discomfort, etc. We also know that pressure injuries and medical illness is likely to increase constipation. If they're constipated, then we need to consider whether or not it's what we used to call obstipation. I'm not sure if they still use that term, but in the old days, obstructive constipation was referred to as obstipation. And essentially, this is constipation that prevents the passage of stool or gas. These are the symptoms: abdominal distension and bloating, dehydration, malaise, nausea, vomiting, and autonomic dysreflexia, increased spasticity, all associated with obstipation. The clinical findings include imaging studies, KUB and or a barium enema that show basically large dilated loops of bowel. And the treatment is volume resuscitation, providing a nasogastric tube and considering mag citrate or PEG from above, with progressive bowel care that with bicicotal magic bullet suppository, digital stimulation, and enema from below. It may be necessary to get a GI surgical consult if the person is not responding to treatment and continues to have significant autonomic dysreflexia. Diarrhea, you recognize that in spinal cord injury, the number one cause of diarrhea is in fact constipation. And so this is always a little bit of a difficult task to talk to your patients and help them understand, yes, I know that you have diarrhea now, but I think it's because of constipation, and we're going to give you these things to try to facilitate more movement of your bowels, at least initially. Antibiotics, so those folks who've developed C. diff and that are on antibiotics, you're going to have a change in the gut flora, and that can also contribute to diarrhea. Spicy foods and caffeine, as mentioned before. And then if you do have things like bloody diarrhea, abdominal pain, distension, fever, dehydration, then recognize that you may be looking at some sort of an infective type of process. Serious complications include autonomic dysreflexia. Recognize that a number of these things can also occur, including SMA syndrome, compressing a part of the duodenum. And then seems like we have a higher degree of cholelithiasis in persons with spinal cord injury above T10. So just recognize that bag full of stones. While the surgeons come by and they check and they say, oh, there's no rebound tenderness, the person is asymptomatic. If my person is having autonomic dysreflexia in response to a fatty meal, then that is in fact symptomatic, and we need to have a higher discussion with the surgeons as we go through there. So psychosocial effects, as it would affect you or I, accidents in public can lead to social paralysis and subsequently loss of work time and depression. So the key education here is bowel education and assessment as necessary. So I've got a couple of minutes left. Would happily answer any questions, thoughts, or concerns. I don't see anything in chat.
Thank you, Dr. Gitter. I'm curious if there's been any recent research on gut microbiome changes pre and post SCI, I guess it'll be difficult to assess, but at least post SCI, and if there's any treatment modalities maybe targeting fecal transform.
Yeah, that's an interesting discussion. I've read just a little bit. I know that there's a group in Alabama and another group in Ohio State that are really looking at the microbiome and trying to determine if they can make changes. So with fecal transplants, et cetera. There would seem to be some basis for this, at least in the non-spinal cord injured population, but we haven't seen that same type of efficacy with spinal cord injury to date. Again, I'm aware of 2 ongoing trials at the moment, but I can't really tell you heads or tails which way that's going to turn out, so to speak. Excellent question, though.
One other thing I just wanted to mention was I was talking about this with some of the other staff about working on the smart order sets you had mentioned earlier. And I don't know if you have maybe some time this week or next week. I wanted to see if there was some changes we could make to our existing SCI order set or some of the other ones, because a lot of these orders are just, we save them as our own personal favorites, but they're not in any Cerner order sets, and that would be really helpful for the next year's residents to have.
Interesting. Yeah, so I've been working with Tricia DeVoe, as you guys have as well. And we had recently gone through a number of these power plans, as they call them. I will have to reach out to her and see where we are with those. My understanding was those were just about ready for full implementation.
Okay.
So follow
I
up
hadn't
with
heard about
me.
that. That's cool. That's great.
Yeah, if you haven't heard anything in the next week, Nathan, please follow up with me and we'll look into it together.
Sure thing. Thanks.
Great.
Thank you, Dr. Gator. After just finishing the SCI rotation, I did see those new order sets. I think maybe a little bit of training as to, how to use them effectively could be beneficial, or even just like between ourselves, that could be helpful. I also had a question about, so enemas are like less indicated or like a later line therapy, is what I gathered from your presentation, and not really something that is preferred.
Right.
Do you have a kind of, what was that?
Bottom tiered, yes.
Bottom tier, indeed. So I was wondering, do you have kind of a scaffold or escalation of care before you would even select that? How do you approach that?
Yeah, I typically will try to get more aggressive, depending upon what their circumstances are. Are they having autonomic dysreflexia? Are they responsive to those kinds of things? If it's a lower motor neuron bowel, I recognize that I'm not going to have much choice because they're not going to respond to chemical stimulation and digital stimulation. However, moving forward, as we talked about obstipation, putting an NG tube in, touching them with mag citrate from above, and then consider from below, if necessary, I would move forward in order to get the fecal material to move forward with a soap suds enema.
Thank you.
Great.
Dr. Gator, I have one question. It's Eddie.
Yes.
When it comes to hydration, there are different recommendations, and maybe Alicia can join in. There are different recommendations how much fluid we should take daily, and some do take into account our body weight, some do not. If you want to be more specific, rather than providing a wide range, how much we should hydrate, what do you personally use? What recommendation?
Yeah, 2 to 3 liters. Now, my residents know this, and you wouldn't necessarily, but we're going to do our neurogenic bladder lecture next. And we'll be talking about the fluid intake to provide appropriate GI health, and yet not leading to having to cath more than 6 times a day. If you're having to cath more than 6 times a day or every 3 hours or something like that, that's way too frequent. And the likelihood that you're going to distend the bladder, potentially leading to autonomic dysreflexia and spasticity because of that, is going to be much greater if you're taking in more than 3 liters of fluid. Recognizing also that most folks will hold some fluid in their legs during the course of the day, and then when they lay down at night, they may have some very large bladder volumes. So we'll discuss that a little bit more detail in the next lecture on neurogenic bladder, but that's what I meant by balancing out between the bowel and the bladder management, recognizing that too much fluid could lead to autonomic dysreflexia, because of distended bladder. Too little fluids could lead to autonomic dysreflexia because of constipation. So that's the balancing act that we are literally trying to figure out with intake and outflow.
Thank you.
You bet. All right, everyone, have a wonderful day. My gut feeling is you've got this and understand it now.